Hi everyone, I'm Vincenzo Berghella and welcome once again to AJOG MFM Live. My pleasure today to be here with Mhatre. Good morning. Can you introduce yourself?
Absolutely. Thank you so much for having me, Dr. Berghella, and welcome everyone. Thank you so much for joining. My name is Mhatre. I am a maternal fetal medicine attending at Tufts Medical Center in Boston, and I'm currently the Associate Fellowship Director at for the MFM Fellowship Program at Tufts. Thanks so much for having me.
No problem. This is something new. We wanted to start, hopefully on a monthly basis. We'll go over quickly, in hopefully 10 minutes or less, some AJOG MFM highlights.
Yeah, so what we wanted to do, there's so many fantastic articles that have been published in the August issue, but what we want to do is highlight a few articles that we thought would help with patient management or counseling for anyone who's taking care of obstetrics patients, and not just our MFM colleagues, but also OBGYN generalists, midwives, and advanced practitioners, anyone seeing them in the office or on the labor floor. So to keep it short and sweet, these are 4 articles that we are going to review today, and you can feel free to go online to look at these articles in more detail. Dr. Berghella, would you like to start?
Yeah, the first one is from Dr. Bender. She did this work at HUP, and she did a randomized trial. The AJOG MFM is really big on randomized trial. This is a wonderful one, looking at oxytocin versus oral misoprostol for pre-labor rupture membrane induction in nulliparous with a unfavorable cervix. So the main question was, what's the best method to start this induction of labor? Historically, it has been oxytocin, but oral misoprostol, we use it more and more. Is it good for people with rupture membrane at term? And here are the methods. Again, a randomized trial, nulliparous patients, 36 weeks or more, unfavorable cervix, oral misoprostol, kind of the intervention to study versus the control oxytocin, which is the standard of care, looking at time to delivery, some secondary outcomes, and a couple of planned subgroup analysis. They were able to recruit 108 subjects and found no difference in time to delivery overall. But interesting, in obese patients and in those with a cervix already 1 centimeter or more, they found almost 4 to 5 hours shorter time to delivery. They also find overall a higher patient satisfaction and no difference in C-section, choreo, or neonatal outcomes or maternal outcomes. So the key takeaway from this quick, well-done randomized study, it's that the best method to start induction of labor in nulliparous patients with an unfavorable cervix, and it's probably oxytocin, which has a similar time to delivery, but higher patient satisfaction and no change in cesarean delivery. So most of the prior data was on oxytocin. I think at Jefferson, and I know at Penn, where Whitney came from, that's what they use, and I think we'll continue to use this, but we'll look forward to more of these trials because, again, somebody with rupture membrane at term is going to get induced, and the quicker, safer labor after the induction, the better for mother and baby. Why don't you take the next one, Mo?
Yes, so this study was evaluating the association between the actual number or size of fibroids and the risk of preterm birth. We know there's an association between fibroids and preterm birth, but trying to characterize that relationship a little bit better was the interest of this study group. And so what we were trying to evaluate here was using a multi-center retrospective cross-sectional study with singleton pregnancies alone who had an prenatal diagnosis by ultrasound of either having fibroids or no fibroids. The team looked at the rate of preterm delivery and they stratified it over a number of gestational age milestones. And then they looked at the number of fibroids, either 1, 2, or at least 3 fibroids. And then they put categories of size, small ones less than 5 centimeters, more medium 5 to 10, and then large ones of over 10 centimeters in size. They had over 4,000 patients with at least one fibroid, and compared to 61,000 patients without. Overall, the preterm birth rate was 8.6%. And what they found is that having at least one fibroid increased your rate of a preterm delivery less than 37 weeks, regardless of size. And then having more and more fibroids between 2 and at least 3 would increase an earlier preterm delivery. They also found that increasing size correlated with a higher chance of a delivery less than 34 weeks, and particularly the large ones of over 10 centimeters in size increased your rate of a delivery of less than 28 weeks. So the key takeaway from this study is that having a fibroid, regardless of the size and regardless of the number, does increase your rate of a preterm birth less than 37 weeks. But there seems to be a association as the larger the fibroid, the more fibroids you have, the severity of preterm delivery also increases. And I think this is really important for counseling patients. I didn't always think that having one fibroid less than 5 centimeters would have much of an impact, but there seems to be this association, and it's important to counsel patients on preterm labor symptoms and signs when you notice they have this history.
Yeah, I think, the fact that they have more than 4,000, people with fibroids kind of made the difference statistically, and they could find those small differences. The next one we'll review is early versus delayed amniotomy in individuals undergoing pre-induction cervical ripening with transcervical Foley balloon, a meta-analysis, an important one, again, like most say, kind of clinically significant. So again, they were looking at timing of amniotomy after cervical ripening with Foley and C-section as main outcome. Here are the methods. Early amniotomy was kind of soon after Foley expulsions in this randomized trials. Delayed amniotomy usually was either after active labor or in 4 hours or more after the initial agents or other agents, as you can see in this slide. They found 5 randomized trials that they could include in this meta-analysis of randomized trials, 849 patients, and the primary outcome, cesarean section rate, was not different. So important to know that if you do an early amniotomy, you don't change the cesarean section rate. But as shown in most other studies on early amniotomy, the time that you deliver is shorter, an hour and a half less, and from Foley expulsion to delivery is 2.5 hours less if you do early amniotomy soon after the Foley gets expulsed, which, as you know, the longer you're in labor, the more choreo, the more, postpartum hemorrhage, etc. So shorter labor, even by a little bit, and this was significant. It's an important outcome. So the key question and takeaway is that after a patient has had cervical ripening with a Foley balloon, which is now what we do almost all the time, if a balloon can be put in, we often use 2 agents, often Foley and some kind of misoprostol. Then when the balloon comes out, and we actually take it out often at 12 hours, if not even at 6 hours, because there are some studies that we published in the Pink, the 6 hours is okay. And then we rupture membrane right away, because early amniotomy does not increase the rate of C-section and it shortens the time to delivery. Again, another important clinically significant study. Next. Oh.
Yeah, and to wrap up for our last study that we're going to review today, this is a systematic review on music interventions during pregnancy. Very different than the other studies that we were highlighting today. This study group wanted to look at music interventions and how it related to changes in blood pressure and changes in scores of maternal anxiety, depression, or stress. So this was a systematic review of RCTs. They looked at having at least 3 music interventions. They could be passive or active, meaning just listening to music or requiring them to sing along with the music, and compared it to having routine prenatal care, routine blood pressure management, or just resting as one of the controls. They compared standard blood pressure measurements across patients, and then looked at these validated questionnaires to assess maternal stress, anxiety, or depression. So they found 14 RCTs with over 2,000 pregnancies that were exposed to at least 3 music interventions. And the trend was quite positive, that there was signs of reduced maternal stress, anxiety, and depression, as well as blood pressure improvement. Importantly, there was quite a bit of heterogeneity amongst the studies. Because the number of interventions varied, the length of time, anywhere from 10 minutes to 60 minutes varied, whether they participated as singing or just listening. But it is an interesting finding, and certainly something that can be important when we want to provide patients maybe a holistic approach to managing their anxiety or issues with their blood pressure during pregnancy, and along with their other standard management. So it does appear that at least 3 music interventions in pregnancy can improve blood pressure, as well as maternal anxiety, depression, or stress.
Beautiful. No, so we reviewed 4 articles on AJOG MFM Live. I hope you liked this format. Send us certainly some feedback. Go to ajogmfm.org and you'll find these 4 articles. And obviously, at this point, thousands of more on the Pink Journal. I want to thank you, Mo, for being with us. We kept it on time, and we want to wish a wonderful day to everyone who's watching around the world.
Bye. Thanks for joining.
Thanks. Bye-bye.